Welcome to the first Institute for Health Policy Studies Health Services Research Symposium. I'm Joanne Spetz. I'm the director of the Institute for Health Policy Studies, and we are kicking off this first session of the Health Services Research Symposium today. We're very excited to be doing this. We have two guests for our panel, which focuses on health policy in the new Biden administration. But before I introduce them, let me introduce Dean Talmadge King to provide some opening remarks for our symposium. Talmadge?
Thank you for the introduction, Dr. Spetz, and for your leadership of the Healthforce Center, your extensive mentoring and teaching endeavors, and of course, your newest role as the director of the Philip R. Lee Institute for Health Policy Studies. I'd like to welcome everyone to the first session of our inaugural UCSF Health Services Research Symposium. UCSF has a long history of health services research, being the first health sciences campus to establish a health services and policy-focused institute, the Institute for Health Policy Studies, which was founded 49 years ago by Philip R. Lee, for whom the institute is now named. We now have many UCSF scholars who conduct health services research in many departments of the School of Medicine, as well as in the schools of nursing, dentistry, and pharmacy. This research is often interdisciplinary and shapes healthcare practice and policy here at UCSF, in California, and nationally. Even though we have a long and rich body of health services research at UCSF, we've never had an event to showcase it and share our knowledge with each other. This event will do just that. We are excited that so many departments, institutes, and schools across our campus are sponsors. Thank you for joining us, and I'll hand it back to Dr. Spetz.
Thank you very much, Talmadge, for your support of this endeavor, and to all four of the professional schools of UCSF for being sponsors of this symposium, as well as numerous departments, too numerous for me to list, but they are all listed on our website, as well as in the opening and closing slides from this symposium. So as I noted, this is the first session of the symposium, which was originally scheduled as an in-person event last May. And we are excited to bring this to a wider audience in this virtual format now. It's a 4-week series, and coincident with our live sessions on Wednesdays at noon, we have a Twitter going actively where there are posters being shared on Monday, Tuesday, Thursday, and Friday to highlight innovative research by colleagues from throughout UCSF. The session today and the sessions over the next 4 weeks are also going to be live tweeted at our handle, which is at UCSF_IHPS. So please follow us and keep an eye on that. The session is also being recorded and will be on our website for those of you who missed the session or have to leave early. So today's presentation topic is how might health and pandemic policy change in the Biden administration? And there already have been some changes underway. So we have two expert panelists today. We have Larry Levitt, who is the Executive Vice President for Health Policy at the Kaiser Family Foundation. He oversees the foundation's policy work on public health insurance, the healthcare marketplace, the Affordable Care Act, women's health, and global health. Prior to joining KFF, he served as a senior health policy advisor to the White House and the Department of Health and Human Services, working on the development of President Clinton's Health Security Act and other initiatives. Prior to that, he was the Special Assistant for Health Policy with the California Insurance Commissioner. Our other panelist is Eric Goosby, who is a professor at the UCSF School of Medicine. He is an internationally recognized expert on infectious diseases and has been serving on President Biden's coronavirus task force, as well as California's vaccine committee. He also serves as the UN Secretary General's Special Envoy on Tuberculosis. Dr. Goosby was the global AIDS coordinator for President Obama, which included implementing the president's emergency plan for AIDS relief, known as PEPFAR. Prior to that, he served as the founding director of the Ryan White Care Act starting in 1991 and served in the Clinton administration to expand that program. So we could not have better people to think about what's going to be coming in the next 4 years around health policy in general, as well as specifically what's going to be happening with the pandemic response. So I have some overarching questions that we hope to get to, and we also are eager to have audience questions. Please type those into the Q&A box. That is where we will be looking for questions, and we will be going back and forth between my own questions and yours. My overarching question, what the Biden administration and Congress should be doing to improve access to healthcare, what it should be doing to deal with the coronavirus pandemic, both with respect to reducing mortality and morbidity and to reestablishing public confidence in engaging in normal economic activity. And what opportunities might there be to advance California's policy proposals with respect to both pandemic response and to other initiatives like the Healthy California for All Commission, the Master Plan for Aging, and the Future Health Workforce Commission. So as I said, please put your own questions in, but I'd like to kick off the conversation by asking our two panelists, what are your top 1 to 2 recommendations for the Biden administration and Congress? And I'll start with you, Dr. Goosby.
Thank you, Joanne. It's a real pleasure to have an opportunity to talk with you and your colleagues today, and it's always a pleasure to see Dean King. I think the outbreak of COVID challenges the Biden administration to use that outbreak as a catalyst to tee up discussions about disparities that are prevalent as you look across populations in our society, minority populations in particular, and then individuals with comorbidities, et cetera, continue to be the predominant, disproportionately represented in hospital admissions and deaths. But I think it doesn't matter what disease you identify. COVID is just highlighting disparities that are really present across the portfolio of diseases, both infectious and NCDs. The Biden administration is trying to use that COVID moment of the outbreak and the disparities that it uncovered to catalyze the conversation about disparities in generally accessing healthcare in our populations and how they run through our urban and rural settings, and to use that disparity measure as the outcome that justifies federal dollars coming into those communities. So that becomes the trigger for federal funding. So really trying to put a purse string around that COVID moment to bring it back into not only international, but domestic focus.
All right, Larry, I'll turn it to you.
Sure. We clearly flipped a switch on January 20th when it comes to health policy. It's a dramatically different direction already than we've seen for the last 4 years. I think as Eric talked about, COVID is clearly the top priority, the top initial priority in healthcare and just in general for the Biden administration. And we started to see that already in the last few days and today with the first briefing from President Biden's COVID leaders, with a particular focus, as Eric talked about, on disparities. The vaccine rollout is certainly exciting. It's exciting to see that light at the end of the tunnel, but we're already seeing all the disparities we've seen in the pandemic playing out with vaccine distribution as well, with some of the early data showing disparities by race and ethnicity in who's getting vaccinated. Beyond COVID, during the campaign, President Biden laid out a sweeping agenda for improving health coverage and affordability, and has started to roll out proposals to accomplish that. I think the key aspects, it's really a two-pronged approach, working with Congress, but it's going to be very difficult to get things through Congress with slim Democratic majorities in both the House and the Senate. I would expect the focus there to be on building on the Affordable Care Act, in particular, improving the subsidies or premium help under the ACA, and then also addressing the low-income people in the dozen states that have not expanded Medicaid under the ACA. who really have no option whatsoever for health coverage. So that's one prong through Congress. And then the second prong is using ample administrative authority to first undo a lot of what the Trump administration did in restricting coverage in Medicaid through things like work requirements, in expanding short-term plans that don't follow any ACA consumer protections, including covering people with pre-existing conditions. I would expect, in fact, as early as tomorrow, President Biden to reopen enrollment under the Affordable Care Act in the midst of the pandemic. And then I think the Biden administration will also look to use their administrative authority to go further. I mean, to address drug prices through waiver and demonstration authority, and address racial inequities, not just in the COVID response, but more broadly, as Eric talked about.
Great. I'd like to turn back to the vaccination effort and the disparities related to that, as well as just the general logistical challenges of trying to do what we are trying to do with such a large population and country. So I'll kind of ask a dual question to Dr. Goosby. What are, in general, the biggest challenges you see now? And related to that, what are some of the strategies that can be used to get some of our most vulnerable workers, including healthcare workers, more rapidly into vaccination? And I ask that last piece because I have heard from colleagues at United Health Workers that they've been trying really hard to get the janitors, the transport staff, the laundry, workers. Those individuals in nursing homes and hospitals also are highly exposed. But it sounds like the vaccination take-up rates have not been as good as they might have been for doctors and nurses thus far. So I think we have a logistic question and then an equity question. And I'd be really interested in hearing some of the strategies you could see moving forward to try to address those.
Yeah, they have been the focus of much of the discussion, Joanne. And I think that strategies that aggressively identify kind of captured populations there's been an attempt to take full advantage of that. The biggest challenge has been in understanding what the Trump administration had engaged with in way of agreements with both CVS and Walgreens pharmacies to cover the vaccination of long-term care facilities. This was a decision that was made in the summer by the Trump administration, talked about, but an implementation plan, as it turns out, was never created. So the charge and agreement with Walgreens, CVS occurred, but they in turn were waiting for the federal government to tell them which long-term care facilities in their specific area they were responsible for, so they could hire new people to leave the site of the pharmacy and go out into long-term care facilities, administer shots in settings that they had no real emergency control or responsibility for making sure was in place. So resuscitative efforts for a potential anaphylactic reaction, et cetera. Our ability to understand that was as difficult, was really not met with a response from the Trump administration internally in the transition dialogue. So we had to go to the administrative leadership in the pharmacies to ask them what the discussion looked like, as we also did with the states, and had to piece together, instead of just being told that it wasn't done, that it indeed was not available. And we had to kind of reboot the self-expectation that needed to be backed up, engaged, understood, and then move forward. We made the decision not to restart dialogue and kind of engage in a process that develops a quote new plan. We went aggressively at identifying where each of the 50 states was in its awareness of their role and how far into implementation they have gone, and found that the third confounder was that separate relationships had been engaged with United Health, Kaiser, Sutter Health, Dignity Health, in given regions that were outside of the dialogue, nor were the departments of health in those counties included in those agreement discussions. So the counties, as well as the state departments of health, did not have any idea of what the total allocation of vaccine was to those entities themselves, which they became aware when they were delivered, but the aggregate count for a region or a state, let's say the 6 counties that come into the Bay Area. And that right there took us 3 weeks to understand after the transition started that that's really where we were. And in all honesty, the ability of those within the US government at lower levels, not political appointees, to speak freely to our inquiries was stifled. So it was really a very frustrating start. And it took us 3 weeks to realize we needed to talk to the states and local cities directly.
Pretty amazing the degree to which the transition communications or lack thereof are playing out. You know, I have a related question to this that maybe Larry has some insights to. You know, there have been so many people who have lost their jobs or been furloughed or had other economic dislocations because of the pandemic. And, you know, in large part based on some of the research, because people are just choosing to stay home regardless of what their state governments are doing. How much information is there about really the extent of the impact, given that early on we know some of the Bureau of Labor Statistics surveys seem to not really quite be capturing all the phenomenon? And how can states do a better job of providing and ensuring that those individuals have access to healthcare services? Because that's very many of the same populations that might be more vulnerable from what we understand about the risk of contracting COVID, having serious illness, not to mention all the other health disparities that we know about.
Yeah, we have, you know, this cuts across so much of healthcare policy. We've have very poor information about kind of real-time information about health insurance coverage. You know, we've got a good idea on a monthly basis of how many people have lost their jobs. We know inflation. You know, we know GDP on a monthly basis. Health insurance, at best, we find out about that, you know, once a year. And it's a retrospective measure, you know, what happened last year. So we really don't have very good statistics on people's current health insurance coverage. Piecing together different elements of administrative data, survey data, you know, we think several million people have lost their job-based insurance during the economic crisis fueled by the pandemic. You know, many of those have been picked up by the safety net, which is now a much stronger safety net with the Affordable Care Act. You know, in the 39 states, including DC, that have expanded Medicaid, people who've lost their jobs either qualify for Medicaid coverage or qualify for help in the health insurance exchange under the ACA. And some of what we've seen, I mean, again, these economic and racial inequities playing out in the economic crisis as well. I mean, you hear about a sort of K-shaped recovery. I mean, the job losses have been just incredibly concentrated in low wage occupations, people with less education, people who are Black, people who are Hispanic. You know, in general, white collar, higher paid jobs. You know, people have been able to work at home, like us. And have not suffered that kind of economic dislocation.
Right. And, you know, in that context, you know, for Dr. Goosby, how should we be thinking about the kind of application of resources? You know, I'm an economist, so I tend to focus on the idea that resources are scarce. So how do we focus our resources on the prevention of the transmission of disease versus the vaccinations versus, you know, trying to address the economic dislocations? And when do we know that the economy can kind of open back up? Is there, Is there a policy that can spur that or should spur that, or should we let the public decide? I'm interested in your thoughts on that.
Well, I think that our ability to reopen has been fraught with stuttered starts and stops, largely because of initially a poor understanding of how the virus had already moved through the population, and our handle on what mitigating interventions we were able to deploy to contain outbreaks once identified. Much of the early response in the United States did not reflect a case finding or contact tracing intervention. To a large degree, it still does not. But that need for decreasing the total number of new cases, as that moves down back into a manageable range, and number of individuals, new cases, we've got it now modeled out. So we know in a given area, the number of new cases that will end up in emergency room visits, that will end up in admissions, that will end up in ICU transfers and intubation. Generally, pretty good model at this point. Tells us that our ability to get the R naught down and below 1, staying there for a 4-week period, as the number of ICU beds opens up to greater than 15% for, again, a 4-week period, we then are going to start a trickle in a reopening strategy. The reopening, though, is going to be confounded by the reopening in schools concomitant, and that's kind of an unknown as to how that will play out. And the maldistribution or variable distribution of PPE within those reopening settings. We want the PPE discussion and deployment to occur before. We want to have thought about case finding, contact tracing, engagement once reopening starts. Are we ready for it? And then we want to do it. The schools are going to reopen kind of in a separate cadence, and we are going to react to that as the Department of Health, and then also the departments, the 6 counties coming to the Bay, are now talking together really in planning on that reopening moment. So I think we'll do it better this time. I think the mayor in San Francisco is now at a point where she couldn't be more frustrated. With all the success she's had, she is still getting attacked by the entertainment and hotel industry is being buried, if they aren't already in many instances, and their attempt to recoup and recover, they're now talking to her about they don't think they will be able to do that in many instances. I'm not in any of those conversations, but I am looking at the mayor's reaction and kind of escalating in her sense of urgency around it. So we're really trying to be as transparent as we can at the local level. And we're now going to try to bring that to the federal level, which has had difficulty doing that.
Mm-hmm. So, one comment that you made, Dr. Goosby, brings me to another question I'll ask Larry Levitt about, which is, kind of that whole contact tracing, surveillance, understanding the cases. This all seems to tie into the profound underinvestment in public health infrastructure in the United States. And of course, now we have seen a lot of mistrust and skepticism of the CDC's capacity, which was very challenged over the past period of time. And I know that there's a goal to try to shore that up. So Larry, how do we go about that? How do we address this public health infrastructure piece? Or do you even see that there's a pathway forward? Or are we going to return to same old with a focus on our medical infrastructure?
Well, I think there's a 50-50 chance that after we come out of this pandemic, that we either forget about public health once again and go back to completely underinvesting in it, or we take this as a lesson that we need public health. We need a public health infrastructure to be there, kind of on call in situations like this. And it's not just, it's not just public health departments, as we've seen. It's the ability to plan across the healthcare system. We have this largely private healthcare delivery system, which has not been well equipped to respond. Whether it was early on with shortages of ventilators and PPE, our ability to roll out testing in any systematic way, has been disappointing from start to finish. And now we're seeing it with the vaccine too. I mean, you listen to what Eric talked about, right? I mean, the lack of transparency, the lack of coordination that we've seen between the federal government, states, local health departments, healthcare systems. I mean, right here in the Bay Area, people, you understand how confused people are when they see, eligibility and access to vaccination varying from county to county within the Bay Area, and then even within counties from healthcare system to healthcare system. So our lack of ability to kind of plan systemically has definitely hurt us, and is very different from what we see in other countries. So we do, hopefully coming out of this, we can think about public health differently and not think about our healthcare system as a curative healthcare system on the one hand and a preventive and public health system on the other hand, and we can think about it a little more holistically and fund it accordingly.
Mm-hmm. Yeah, one of the questions that was submitted, I think, gets into some of this vaccination and lack of consistency area. So I'll ask it to Dr. Goosby, but you can jump in too, Larry. So Robert Valdez asked that a lot of the focus on the vaccination priority has been on age, which of course, given the impact, especially in nursing homes and for people in the oldest age groups with the risk of severe illness, makes sense. But then some counties are continuing to focus on age, which perhaps does not align with some of the equity discussions that have already been alluded to today. So I'm curious what your thoughts are about how we can hit that balance between the medical risk, the equity issues and access, and what kind of a approach and effort should be undertaken or will be undertaken to try to balance that out and reduce the confusion that people have about it.
You've hit the challenge of vaccination in a setting where there is a lack of clarity about the number of doses available. There is an insecurity around the supply chain that brings them to us or to the individual to dispense, and the lack of clarity on who is a recipient in any given county or state of batches of federally launched vaccine deliveries, which we are now getting cleared up this week, gives us a very cloudy picture of where we were in the start. I just want to really echo what you both have said, Larry's reference to the degree to which our healthcare delivery systems are decentralized, confounded our response for COVID in San Francisco and in California in a major way. Our attempts in the first week of outbreak in the city with the Department of Health to engage with the insurers of the citizens of San Francisco, Kaiser, Dignity, Sutter, et cetera, was first met with did not want to engage, did not think they had a role in the public health response, had never self-perceived themselves as being staffed to respond to that, and even went so far as to say in their contracts with patients who, give them a monthly allotment for their health insurance and coverage, argued that it wasn't mentioned in any of the legal back and forth around that. So after a couple of weeks, they realized that this was not an argument once their lawyers got into the discussion, and they came back to the table with a genuine attempt to what can we do together? But still, it was all money framed, understandably, but at the same time, we wanted to get the need on the table and discuss the need, and then how do we pay for it would modify what we did, for sure. But I just want to underline the degree to which decentralized healthcare preempted our ability to put a coordinated response in front of the virus as it moved through the population. And because of our inability to garnish testing, so it was strategic and informed our deployment of resources, which it never really has, we never mapped out where that virus was moving in the general population, and still to this day have not. So it's going to continue to be a problem. The genomic surveillance is another issue as the variants come in. That's kind of another discussion, but related.
I mean, I'll pick up on what Eric was talking about. I mean, we see it also in testing, right? I mean, insurers have resisted paying for surveillance testing. I mean, they're required to pay for a test for someone who is symptomatic, but they have resisted any kind of broader testing for people who have potentially come in contact, or for certainly for broader surveillance testing in a pandemic. And this is during a time when insurers are actually more profitable than they have ever been, because people are using less healthcare other than COVID treatment during the pandemic. And then just coming back to Bob's original question about the priorities and equity issues. There are no right answers here. I mean, we're in a situation where we have inadequate supply. Hopefully by the summer or during the summer, supply will free up substantially. But right now, we do not have enough supply of vaccines to get to everyone. And so you have to set priorities. And there are no good answers here. I mean, starting with people who are older, particularly people in congregate settings like nursing homes and assisted living facilities. I mean, they are clearly at the highest risk of both infection and serious illness and death. After that, it gets a lot harder. I mean, older people, even into their 60s and 50s, are at higher risk for illness. On the other hand, people who are in essential jobs, who are lower income and more likely to be people of color, are at higher risk for infection. Grocery workers, food service workers, people working in warehouses, first responders, and how you balance those is just really hard, and there are no good answers. And I think part of what we have maybe gotten a little bit wrong so far is making it too complicated. The complexity has been an enemy in the vaccine rollout so far.
Right. So, one suggestion or question that came up in the submitted Q&A, it actually showed up in the chat, but I do encourage people to put it into Q&A so it makes it easier for me to track these. Was the idea that I've seen published from Charles Phelps and other people is to have maybe something akin to a National Guard that is actually a public health guard that could have two purposes. One is much like the National Guard, you have a temporary workforce that's available to serve, say, an urgent public health need. That could be anything from an emergency response after a hurricane or a fire through a pandemic, which we hope we don't see again for 100 years. And also it could be kind of a job safety net as well, that the time you would need to call on it might be actually drawing on and providing some work for people who are exactly the kind of people who might be at more at risk for losing their jobs and have some good skills to bring to the table. But, and then you would have regular training, much like the National Guard, and a stipend for that, and so on and so forth. So I'm curious what you think about that idea and other approaches we might want to be thinking about forward. We obviously have an emergency to deal with, but there is a need to think about what the infrastructure needs to be for the long term.
Well, I could take a first shot at that, and then I know Larry's thought about this a lot, but the Biden administration, just to cut to the quick, has proposed a public health workforce that would be exactly what you're describing. The Public Health Service, which has existed since the late 1700s, was created with all of those functions outlined as well. But they've taken an unusually serendipitous course over the years and are kind of a different animal now. With the closure of the public health hospitals nationally, they really changed. However, a reinvigoration of that core, which is already on the books, so to speak, and basically set up to respond that way and has a long-term intimate relationship with the Indian Health Service. With the Affordable Care Act rejuvenation is something that has been talked about and will be done by the Biden administration. So they've already bought that as something that would help. They've also thought about it with more technical capability, specifically looking at the model that UCSF did with Navajo Nation in deploying anesthesiologists, pulmonary specialists to help with the critically ill in the Navajo hospital. That's still ongoing. It became an example of how a technical assistance capability could really run the spectrum from administrative logistic needs to technical TA.
Yeah, I think I'll jump in. I think public health guard, that idea really gets to the heart of our challenge in responding to a quickly moving pandemic like this, which is that we don't have a ready workforce to address needs, and that we don't have funding available to then respond in a quick way. And again, back to vaccines, it's a perfect example. The Trump administration put the responsibility on states to do that last mile of vaccine distribution. And the total funding for all of this past year was a couple $100 million. It wasn't until December when Congress passed the COVID relief package after the election that there was finally, beginning to be sufficient funding to allow state and local governments to actually fulfill their responsibilities here. So you kind of need some funding mechanism that's kind of there for emergencies, like we have a military. We don't have wars all the time. And you need that workforce. One thing we haven't talked about, for example, is contact tracing, which has been a huge failure throughout. I mean, we haven't gotten it right yet. And right now we have way too many infections to even begin to contact trace. But we needed many times the number of workers to do contact tracing than we had available. If you had this kind of ready workforce that was already trained, that could be called up, you could move much faster.
I'll ask about another area that seems to be resource constrained is the personal protective equipment. And especially with the more contagious variants, you're seeing that issue come back up of whether we should have been using cloth masks only as a temporary stopgap while we had a big ramp up of N95s. So what are the directions we should be going in, and what are some strategies we can use to ramp up the production of PPE, and also think about where and when it should be mandated? We have the mandate for the federal buildings, possibly school reopenings, what could be done there? What about air travel? What about interstate train travel? And how do you distribute and make sure that good quality equipment is available to people?
I think the need for PPE was evident. The inability of the federal government to take ownership of that passed a baton to 50 states to get it themselves, which passed another baton to every major city in those states to go after it themselves. So they set up a competition in the manufacturer end of things who were receiving those phone calls where the highest bidder got the PPE, and people started to undercut each other, and that has lasted for months. So I would say we understand it. We are in the process of stopping it and taking back that national orchestration, but have decided a couple of weeks ago not to dismantle anything, build off of things that work, but take ownership of it as federal government. So we stop the multiplicity of phone calls that go to the manufacturer. That same problem is around how we deployed contact tracing. Larry's right. We're at too high a number of new cases to use it. But as we push that hump down, we need to deploy it immediately so it doesn't go back up. And we need to get ready for that. UCSF, Mike Reed and George Rutherford and crew with the city and county of San Francisco really led an effort to engage librarians in being that pool of individuals that were retrained who were out of work. Libraries were closed. So we were able to take all of them and retrain them. They're all still doing it, remarkably enough, in off hours as libraries open back up, or as duties for librarians open back up. They still are the main support. So I think the idea of a public health force is a good one. We've bought it in the Biden camp. So it's now a matter of making it work and maximize it.
I mean, this question Eric raises of, kind of federal versus state responsibilities has, certainly pervaded our response to the pandemic, but it has been there in health policy discussions for a long time. We see it in this question of expanding Medicaid, for example, where the Supreme Court made the Medicaid expansion under the ACA voluntary. It became a bit of a political symbolism, that if you expanded Medicaid, it meant you were, pro-Obamacare and pro-Obama. And 12 states still, primarily in the South, still have not expanded Medicaid. And we probably need to find a better balance, particularly in a public health emergency, between the role of the states. Federal government is not going to take over public health from state and local health departments, but a stronger guiding hand from the federal government, certainly more resources would have been helpful. I mean, if you look at the vaccine distribution, we've got local health departments and health systems scrambling to design, basic things like an appointment system and data systems, with very little help from the federal government.
Yep. Your observation about Medicaid expansions connects very well to a question that Caroline Fichtenberg submitted, which was how might the response have been different in terms of coordination and so on if we'd had Medicare for All in place? Anybody want to speculate on that?
I'll start. I think, there's been some speculation, for example, that, the fact that we do not have a universal healthcare system, has hampered our response. And that's certainly true in some cases. The fact that people are uninsured, decreases their access to care, makes them hesitant to go in to get care when they have symptoms and are potentially infected. And I would say our inability to plan systemically and to roll out things like testing or vaccines have been hampered by not having a universal system like Medicare for All. On the other hand, I think, some of our biggest challenges have been, political and ideological and not anything to do with our healthcare system. The mixed messages around masks, that masks became an ideological test, have really nothing to do with our healthcare system. It has much more to do with our political culture in the U.S. So I think we were challenged by not having a universal healthcare system, but in other ways, our problems went much deeper than that.
In places where there, like in the UK, there were still problems with the NHS and in moving it. I think if I were going to tease out what in our decentralized system of care impacted negatively the most, it was in what Larry said. It was in the inability to have a pathway that allowed for a harmonization of response and effort in PPE, in testing, in now vaccine distribution, in economies of scale. So instead of using the Kaiser facilities that are relatively empty, we're going to stand up something in a parking lot de novo. We're not taking advantage of space opportunities that are already there in those types of things, and personnel. We should, with a pandemic threat, be able to move the resources in response that are needed to respond to the need, apart from how your health plan pays or doesn't pay for the service. There should be a way to preempt that if nothing else.
I mean, I would say one thing we've suffered from, one of our, if you think from a health economics perspective, one of our successes over the last few decades has been moving people out of the hospital and into outpatient settings. And as a result, we have fewer hospital beds and fewer hospital staff to provide care for patients in inpatient settings than in other countries. So that success has actually left us, I think, less prepared to respond now when we're seeing so many people needing hospitalization.
Mm-hmm. Yeah, so another logistics question came in from Cheryl Damberg regarding the wild differences that we're seeing across counties in accessing vaccinations, even for counties that have said we're only doing 75 and up or limiting the ages and trying to be very targeted. Orange County, she notes, has a website that's easy to use. You go on, you pick your location, you pick your time, it's pretty clean. They used a private vendor for that. Any thoughts about how counties can improve what they're doing and make this more publicly accessible and easier to do? Do they need to go to private vendors? Do they have the money to do it? What needs to happen?
Well, to me, the problem is that there is no one in a given county who is responsible for vaccination as it moves into healthcare delivery silos. So the Kaiser, the Dignity, the Sutter Health silos become the recipient of the vaccines from the federal government. They didn't tell the county or the state how many vaccines they deployed to Kaiser. Kaiser distributed those nationally without that sharing of information, nor a mandate or will to coordinate. So not given any of those levers to pull, county health officers were standing kind of caught in the headlights, looking for guidance from mostly the state, who was looking for guidance from the federal government because they didn't know how many vaccines they were going to get until they showed up on the door. So it's kind of problems that are hard to understand how that became the way we did it. It's almost out of neglect that things moved forward more than it was a plan in this particular instance. So
I think it's also, I mean, I have some sympathy for county health departments right now. I mean, it's not only is there no one with necessarily the responsibility, the information, the accountability for vaccines at the county level, but it's the same people who are dealing with the pandemic generally, who are having to deal with vaccine distribution, and they've been working their tails off and getting threats, physical threats to them and their families now for a year. So these are really tough jobs in a really tough environment, and without the resources to do it well.
Yeah.
And Larry, you're really right to say that it has been sustained. When I watch colleagues who are in front of it, it's like for the last 11 months, it has sustained itself as opposed to, intervals of relief. It's really a remarkable moment. And I'd say the same for the inpatient response.
Yep. So I'll turn to another area where Rita Hamad asked another question that has similar complexity and beleaguered groups that don't have great guidance, is reopening schools, especially for the youngest kids. There's huge variation across the country in what schools have been doing, and even within California and between public and private. And a lot of these things are exacerbating disparities. But it seems also that district leadership, in their defense, much like county public health officers, have not been given clear guidance or recommendations about best practices. How do we move forward? What are the plans for guidance on reopening?
So I can just generally say that the ownership that it hasn't worked is total. There's a complete acceptance of that. That the relative threats for teachers and students is complicated. That our attempt to change the environment in schools, spacing and ventilation in particular, have been poorly implemented, partially implemented in most places, very rarely fully implemented. There has been no real resources to pay for any of that. And until the last stimulus package went out, municipalities started to see some of that money for the first time in California. The prior attempts at relief did not trickle down. And our discussion has been, let's get the PPE in place, the testing in place, and the case finding in place within each school system before we trickle that reopening. And that's what the Department of Health in San Francisco now and at the state level is trying to do. A lot of best practices were identified in private schools, and they are expensive. They in some instances were testing students and staff 3 times a week. We think somewhere around 2 is probably enough to do it well after a couple of 3 weeks of monitoring, with a testing as needed available as well. And we are trying to stand that up with, but doing it at the local level, not federal. So that will be more of a regional response. It's a high priority for President Biden and Vice President Harris. So it's at the head of the queue in terms of CDC's, reprioritization of the workload post the transition.
Yeah, I would just add, I mean, I think Eric's point about testing is really important. I mean, irrespective of whether it's 2 times a week or 3 times a week, there are very few sectors, maybe outside of professional sports, where we have kind of done that kind of regular testing in any effective way. And it's going to be really important in the schools, because none of the vaccine candidates are approved for kids under 16, and that's probably not going to change anytime real soon. So that kind of surveillance is going to be really important.
So I want to shift gears a little bit. Robert Lustig asked a question that I think is very interesting about broadening our discussion to the health of the population in general, and not just specific to the coronavirus pandemic. He asked, why have both the Trump and the Biden COVID responses not yet taken on issues around the relationship between the health behaviors of Americans? And he specifically refers to processed food, metabolic dysfunction, immune dysfunctions, and so on, and the broader public health, population health concerns and those intersections with COVID, and how we might be able to tackle those broader concerns, perhaps with the pandemic being a leverage point to draw attention to it.
Well, I'll start with that is the intent. Everyone who was convened to discuss strengthening the COVID response by President Biden, that was the first thing out of most of the mouths there, because they all come out of a historical context of it's not just one disease out there, and have been in front of that. So looking at COVID as the catalyst to have that broader discussion about disparities was the conclusion of the discussion. Stick with disparities, hypertension, diabetes, coronary artery disease, emphysema, whatever you want to name, as well as infectious diseases, but that those disparities, we need to be thinking as we think about this public health workforce, about how we orchestrate the public health response between silos of third-party payers and insurers. How do we create a a cadre that can serve more as a health care worker, case management expansion in that cohort of public health workers, and take on some of the disparities in the NCDs. And that was heavily discussed. And the whole emphasis on disparities and having special assistants that just focus on those disparities in the White House, I think speaks, and setting up a task force around it, I think speaks to the importance that they're putting on it. For Vice President Harris, this is her first, second, and thing that she brings up in every conversation.
Yeah, I think you know, usually in health policy, it doesn't train you to be optimistic, but I actually am optimistic in this, that the pandemic has, you know, really shined a spotlight on those disparities, and it's not just disparities in health. So it's not just higher rates of diabetes and hypertension that put you at greater risk for COVID, for example, and that those vary by race and income. But the underlying economic disparities as well, and structural racism in our system that put people at greater risk. You know, your job. You know, if you're in a job that you can't work at home, if you're in a dense living situation that puts you at greater risk, not just with COVID, but for all kinds of other things. You know, I think coming out of this, there with the much greater recognition of these disparities, that there actually will be a renewed willingness to tackle them in a bigger way.
Well, we have only a few minutes left, so I'm going to close with one last quick question, which could take a long time, but please be brief. And I'm adapting from a question that was submitted by an anonymous attendee. 5 years from now, where do you hope we are, and what would we look back on as the biggest lessons from this response, and what do you hope that we can say, we learned that lesson and we now have this in place to make things better for our country in the future? And it doesn't have to be disease, you know, pandemic related in terms of where you hope we are in 5 years.
That's not a question I get. Larry, do you want to start with that, or do you want me to start?
Yeah, I'll start. It's you know, I think one of the biggest failures in the last year has been our unwillingness to rely on science and just basic facts. And you know, I think we're seeing a change just in the last week. You know, but the politicization of science and basic information, you know, really crippled us during this pandemic. And you know, I would hope, and it's not just about COVID. It you know, pervaded all kinds of other issues as well. So, you know, I think if we can get back to a world where we have shared facts as a country, we'd be a lot better off.
Yeah, that's really nice, Larry. Thanks for that. I would say, just on a little different tangent, that in 5 years, if we could become more aware as a society of the unequal playing field that is present for so many populations that can be easily defined, the surveillance has said it, the data has shown it for as long as I've been a doctor and longer, and we have not reacted to it as a community of physicians and health professionals as maximally as we need to. And I think we also are in the position where we see the results of neglect in a different way than most people in society. And it falls upon us because of that to be a voice that connects the dots for people, because of the deep, the inequities, the unequal playing field, perpetuating the outcomes that we continue to see between racial groups, socioeconomic groups, regional groups, rural, urban groups, you name it, we can show those disparities. And are we not smart enough to counter them? And I would say that we need a discussion that is led by academe, that quantifies the disparity, keeps it on the table so we can't not stop talking about it, but holds the expectation out that it's unacceptable. And I think we have an administration that totally is into this and will run with it if academia can continue to feed the data that supports it. So I think we're at that inflection point.
Well, thank you. I'm going to also note that Dean Talmadge King added in the Q&A or in the chat that he hopes that universal health care as a foundational fiber for our nation comes to play in 5 years. Maybe that's too optimistic, but I will add his comment there because I know many people agree with that as well. So thank you very much, Dr. Goosby and Larry. It's great to see you again and have you with us today. I want to point everybody, quite apropos, our theme for next week's symposium session is on advancing health equity, health services research, and social determinants of health. And the panel is moderated by Kevin Grumbach, who is the chair of our Department of Family and Community Medicine. And the panelists are Laura Gottlieb, Rita Hamad, Tu Nguyen, and Matt Pantel. So thank you very much for everybody joining us today. I hope that people join us next week. It should be a really great session and reflecting back on all the equity issues that we've talked about today. So thank you very much.